As you can see, answers B, D and E are right. A is wrong because primary tumor size is not the thing that limits the patient's prognosis. If you can bring him to R0 resection, he can even be in a curative situation. And C is highly debatable, as we talk later on. Neoadjuvant chemotherapy could be an option, but if you give neoadjuvant chemotherapy, it should be with carboplatin and paclitaxel, and this chemotherapy that is shown here as a chemotherapy typical for breast cancer. Computed tomography of the abdomen is the investigation of choice for monitoring and for diagnosis of recurrence. In the primary workup, it's considerably inferior to vaginal ultrasound. At this stage, computed tomography is only relevant for evaluation of the abdominal lymph node status, but this is not mandatory before an operation. If ovarian cancer is suspected, confirmation of the diagnosis by laparoscopy should not be performed, as port site metastases often develop at the trocar insertion sites only shortly after the operation. If laparoscopy has inadvertently been performed, the trocar insertion sites are resected at the subsequent laparotomy, which should follow within a short period of time. Cystoscopy and rectoscopy are usually also performed preoperatively to evaluate the operation site in the small pelvis. The next slide shows the 2003 FIGO classification. Stage 1 tumors are rarely found. Stage 3C is undoubtedly the most common. Now we come to surgical treatment. If there's a strong suspicion of ovarian carcinoma, laparotomy through a midline abdominal incision should be performed, as this is the only way to ensure the best possible exploration of the abdominal cavity. Pelviscopy, on the other hand, does not allow adequate inspection behind the liver, along the diaphragm and of the lymph nodes. According to the AGO guidelines, which is the German Gynecology Oncology Study Group for treatment of ovarian cancer, the following steps are necessary. ESMO, which is their European equivalent, and ASCO, the American counterpart in this case, are pretty much the same. On entering the abdomen, samples for peritoneal cytology should be obtained. The entire abdominal cavity should be inspected and palpated. Biopsies taken from all suspicious sites and multiple peritoneal biopsies taken from macroscopically unremarkable sites. Both ovaries must be removed, taking care in early stages not to rupture any cysts present. Hysterectomy and at least infracolic omentectomy should be performed, plus appendectomy in the case of mucinous or unclear tumor types. The pelvic and para-aortic lymph node should be removed, the latter up to the level of the vena cava at the junction with the renal vein. It has been shown in more than 20 studies that resection of all present tumor is crucial for the patient's prognosis. To ensure that this is achieved, an ambitious approach should be used for the surgical treatment. This can mean that, in addition to the steps outlined above, for example, partial colon resection with colon anastomosis, if necessary protective stomas, partial liver resection, partial diaphragm resection, splenectomy, cholecystectomy, and partial or complete cystectomy, ural resection with reimplantation, and artificial urinary drainage operations might be needed. Tumors are considered inoperable if there is a marked involvement of the small intestine or if the mesenteric root close to the celiac trunk is involved. At experienced operative centers, complete cytoreduction can be achieved in up to 85% of the patients. The next slide shows the results of a meta-analysis of pooled German data on how the quality of the surgeon has an impact on the patient's survival. The graph shows that it makes a marked difference for the patient's overall survival whether a zero resection is performed or whether, in the red curve, there is even only a minimal amount of residual tumor. This is particularly important, since it was assumed in the past that it was sufficient to aim for residual tumor less than 1 cm. The curve for minimal residual tumor is in fact not very different from the one for macroscopic residual tumor than 1 cm. To illustrate that even larger upper abdomen interventions are justified, let me show you a trial comparing patients with advanced stage ovarian carcinomas that were retrospectively stratified in diaphragm surgery versus none. As you can see, the patients do largely benefit from the extended surgical interventions, which gives us better PFS and OS. Now let us look at the question of lymphadenectomy. The current rule is that this should be performed if a zero resection in the remaining abdomen is possible. However, until now there is no clear evidence supporting this procedure, since the available data do not show any positive impact on overall survival. Randomized prospective studies on this area are in progress. If a zero resection is not possible, only the lymph nodes which are enlarged to palpation and thus suspicious should be removed. In stage 3 disease, lymphatic dissemination has already taken place in a majority of patients. In very young patients who may still wish to have children, an organ-sparing procedure only appears justifiable in patients with stage 1, grade 1 disease. In this case, it's also possible not to perform adjuvant therapy. Let's now have a look at the only available prospective data regarding lymphadenectomy. In the big international lymphadenectomy trial, close to 300 patients were randomized in lymphadenectomy versus none. While as you can see there is a significant advantage in PFS regarding lymphadenectomy, there's almost no difference for overall survival. But main point of critique of the study is that the macroscopic complete resection was only achieved in 37% of patients, which is considerably lower number of what we can possibly achieved in top centers with 85%, as you heard before. So it must be suspected that the overall survival in a completely debulked group would have been significantly better. Prospective trials looking into that issue have already finished recruiting, so that the results are due to be released soon. The next big section focuses on adjuvant chemotherapy. The two Kaplan-Meier curves on this slide show you the absolute difference that adjuvant chemotherapy can make. While adjuvant therapy gives you a better relapse-free survival by 11%, overall survival is improved by 8%. For comparison, this is slightly more absolute difference that an anthracycline taxane-based regimen can hope to gain in an adjuvant medium-risk breast cancer setting. Please do note that the regimes used in the setting are not state-of-the-art, and with modern regimes an even bigger difference is probable. Let me now talk a little about neoadjuvant chemotherapy versus primary debulking surgery. As I said before, in Germany there's a strong trend in favor of doing debulking surgery first. Internationally, there's a strong discussion raging whether chemotherapy should be given first in order to shrink the tumor and then be able to maybe do easier surgery. While some data on this topic exists, this data is highly controversial. A randomized Phase 3 trial was conducted by Vergodi and al. And published in the New England Journal, where patients with suspected ovarian cancer were randomized either to primary surgery or to neoadjuvant chemotherapy with carboplatin paclitaxel and then surgery. The authors found no difference in PFS or overall survival between both arms. Peri- and postoperative morbidity tended to be fewer in the neoadjuvant arm. While one might guess that this settled the question in favor of neoadjuvant treatment, there are some major weaknesses of the study. As critics argue, the complete resection rate was only 19% in the overall cohort, which is, as we already heard, the most important factor. In addition, some centers achieved optimal cytoreduction in only 3% of patients, which raises the question if the surgical expertise was high enough to participate in an ovarian cancer trial. The average OR time of 165 minutes further strengthening this point, as if I tell you that the median OR time in our center is around 8 hours. According to local